Good afternoon, everyone, and welcome to this second session on the Swiss DolorClast method with this webinar. It's a pleasure to be with you, especially in this particular period where we need to adapt and face the situation. So we are happy to bring you some good vibes. And before starting with webinar, I would like to introduce myself. So my name is Mary Christine Colette. I'm responsible for educational activities with the Swiss DolorClast Academy, offering shockwave training programs to the expert users in shockwave of tomorrow. So basically, the Swiss DolorClast Academy has been created by the company EMS Electromedical Systems in 2013. To give you some historical background, EMS Electromedical Systems invented the Swiss DolorClast method at the end of the 90s. So to get back to our webinar, we are welcoming today Daniel Morgan, our expert of the day in shockwave therapy. Daniel, good afternoon. We are so happy to have you as expert today.
Oh, happy to be here. Happy to oblige. It's obviously off the back of the first one as well, so really keen to continue with this. Quite good.
Thank you. And just before giving you the mic, I would like to add a few technical points for our dear participants. So we will have 15 minutes. We will have, 30 minutes before the end of the webinar for the potential questions you may have on the Swiss DolorClast method. So feel free to add and write your questions by clicking on the Q&R icon at the bottom of the top of your screen. We will answer them after Daniel's presentation within 1 hour. So I think I'm okay. Daniel, the stage is yours. So
well, brilliant. Thank you, MC.
Thank you.
Let me just share the screen. Okay, so I think firstly we're gonna introduce myself, then we'll get onto the agenda, etc., etc. Can you all see the screen? You're all happy with that, MC? Yeah.
Yes, perfect.
Cool. Okay, so my background, I'm a chiropractor at Beaches Chiropractic in Port Talbot, which is in South Wales. I was fortunate enough to win the British Chiropractic Association's Associate of the Year in 2018. I completed my Masters in Sports and Exercise Medicine in 2019. And whilst I was completing that, I also completed my postgraduate certificate in medical ultrasound. So I also have a little bit of a sonography background, which comes in handy when it comes to diagnosis and also then treatment of tendinopathy. Most recently, I've been appointed the Director of Academic Affairs for the Royal College of Chiropractic Sports Faculty. So that is part of my role there is to be responsible for the education and CPD for chiropractors interested in sports. So that's a little bit about me. We'll go on to the agenda now. So firstly, before we get into the shockwaves, we're going to touch on the Swiss DolorClast Academy and what is it and its role. We'll then talk about what are shockwaves and the physics behind shockwaves, Swiss DolorClast machines and how they may differ to other machines, the cavitation and how does it work and what exactly is the importance of a cavitation. If you know anything about shockwave therapy, this is one of the key factors of how shockwave works. We then look at the literature and the Pedro database, and then we'll go into the questions come the end. So talking about the Swiss DolorClast Academy, one of our key, or one of EMS's and Swiss DolorClast's key pillars of the Swiss DolorClast Academy is education. So we're still trying to provide the best quality education we can, even given the global climate at the moment. Hence these webinars, and I think that we are looking to do some more in the forthcoming days and weeks as well, hopefully. But what it does is it allows tailored training programs worldwide to support the knowledge about the Swiss DolorClast method. There are 200 plus courses a year run. There is 70 official course trainers in 24 different countries, with over 5,000 certified practitioners in more than 30 countries. So there's a wide abundance of expertise and users worldwide using the Swiss DolorClast method as a result of the Swiss DolorClast Academy. What are the benefits of it? So if you are a DolorClast user, you can, from obviously becoming a DolorClast user on the back of joining the Academy or going to an Academy training day, you can get all of the training protocols, etc., that are available. You can register your practice online as well. So that helps you increase your exposure a little bit. It can drive your business, but also it gives you a little bit more support. There's also this amazing Facebook group that everyone's a part of. And this basically entitles you to ask a few questions to other DolorClast users, and maybe even just pick their brains a little bit and say, well, I've got this case, would you recommend this, 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 and this? There's trainers on that group as well, which is amazing. And that group in the UK was developed by Chris Downton, who's our lead sales person. So this is a fantastic little setup which allows you to basically get support where needed or when needed. So without further ado, we'll get on to the physics stuff, but also I wanted just to show you this little video prior to that. We'll get a little video of what is the Swiss DolorClast Academy and just maybe what it's about, and just give you a little bit of a feel for it.
When pain persists, so do we. We find new ways of being, of healing, and of training tomorrow's shockwave experts to use the Swiss DolorClast method. The Swiss DolorClast method is a holistic therapy that treats pain extracorporeally. There are over 10,000 Swiss DolorClast shockwave devices in use throughout the world today, and even more patients being freed from their pain. Whether it's being used to treat tennis elbow or plantar fasciitis, the treatment is an effective and non-invasive alternative to surgery, steroidal injections, and oral medication. The Swiss DolorClast method has been proven to relieve pain in over 80% of cases after only 3 treatments. Find out more about the Swiss DolorClast Academy at sdc-academy.com and join the movement to bring back movement.
So yeah, that's a little video explaining the kind of what the Swiss DolorClast Academy is and the Swiss DolorClast method, and it's just a really nice way just to introduce things, really. But now we'll get into the shockwave physics, if we can. There we go. Okay, so what are shockwaves? And generally, shockwaves are high pressure sound waves. Now, a lot of people think that this is an electrical impulse, and that's not the case. It's just high pressure sound waves. And they differ to other sound waves because of they're quite high intensity and they are generated at extremely high pressures. So if we look at physical day-to-day examples of shockwaves being produced, that would be an aeroplane breaking the sound barrier. We have earthquakes that produce primary shockwaves, secondary shockwaves, explosions, and this is kind of explosions are the ones that we're going to focus on because they're the easiest to control and to demonstrate. So I'll show you a little bit the effects of an explosion and how we can demonstrate shockwaves in day-to-day life. Now, the key thing that you want to understand from the next 2 videos that I'm going to show you is that shockwaves have very little energy dissipation through water. So what I mean by that is that shockwaves don't lose energy when they're in water. And this is why we have a contact medium. I did have a contact medium, a tube here somewhere, but that's disappeared. This contact medium is like an ultrasound gel, but the EMS one has less air bubbles in it, it has less oxygen in it. So because these air bubbles aren't as prevalent within this contact medium, that in theory reduces the chance of loss of energy through its contact with between the applicator and the skin. So this is what we aim to show you with these next two videos, is that essentially we know shockwave therapy and shockwaves work better when they're applied through water. So here's a video just to demonstrate that. So what we're seeing here is a charge. That charge is causing a lot of ripple around the orange water balloon there, and very little on the red. So what we can take from that is that energy is being lost the further away from the site of the explosion. Now, this isn't a perfect example in the next video, because we don't know if the charges are the same, if they're different, if they're the same distance apart, etc. However, it's just a little idea for you. This is what happens with a charge and explosion underwater with water balloons. Now there's the charge explosion creating a very similar effect regardless of the distance away from that charge. Again, if you're being hypercritical, you could argue that they're not equidistant to the previous video, but at least you can see that, you know, the purple balloon is having a very similar effect to the yellow balloon, which is further away. So that's just a little demonstration of why we use a contact medium. Other people said previously that castor oils and things like that can be used, which is fine. It's just very messy. The contact medium that EMS and Swiss DolorClast provide is perfect for this. So when it comes to the physics of a shockwave, this is something that we always get asked, is that what is it compared to ultrasound? And these next two slides are going to aim to differentiate and explain the difference between them. So shockwaves are defined by 4 key characteristics. There needs to be a high positive peak pressure, a very fast rise time. There needs to be, following that positive peak pressure, there needs to be a negative pressure. And this all happens over a very short life cycle. Now, that, when you compare to ultrasound, is completely different. An ultrasound wave is classed as more of an ossicle. There's significantly less energy that is produced via ultrasound. It has a longer cycle, which means that for one ultrasound wave to be produced, it takes a longer time than for one single shock wave. And the ultimate difference is that it has a less physical effect on the medium in which it passes through. So that would be whether or not it's going to be your Achilles tendon, your plantar fascia, your tendons in general, your muscles, the trigger points. It's going to have a less physical effect on that tissue. So if you look at literature, there will be different types of shockwaves that you may stumble upon. That would tend to be focus shockwaves or radial shockwaves. Now, they come under the same umbrella term as shockwave therapy. The only difference is the delivery and the energy, really, the power that is supplied by both types. So that could be focused, generally supplies higher levels of energy. Radial supplies ample energy, but the way in which it's delivered is different. With focused, what happens is that it becomes more pinpoint the closer to the pathology or the pathological tissue. So it starts really broad and then narrows in. Radial, on the other hand, starts really narrow at the site of shockwave, so that would be at the applicator head, and then diverges. So it has this torchlight effect, does that. Now, as I said, complete opposite with focused. When it comes to the settings, again, now if you look at literature, there will be people out there that will state maybe you have 4 bar energies, or others will state that you use 1.8 millijoules per millimeter squared. Now, they are the same, but different ways of measuring it. Bar is going to be your pressures that the machine is set at. Millijoules per millimeter squared is what we class as energy flux density max. Okay, now that is dependent on the surface area. So what we define that as is maximum power delivered through a defined surface area, and that is going to be your applicator head, so the size of your applicator head. With Swiss DolorClast and EMS, we have 2 main ones that we use, and I'll talk about the importance and the relevance of that now in a couple of slides' time. As I said, these are represented on the machines as pressure or energy. And the key thing with that is to know that there's a conversion chart, which I will talk about again in the forthcoming slides. But there is a conversion chart. So if you're looking at literature that says, oh, you know, we use 3.5 bar, well, what's that in millijoules per millimeter squared? Or I use 1.6 millijoules per millimeter squared, or 0.16, sorry, millijoules per millimeter squared. What's that on bar? I don't know. So that's the relevance and the significance behind mentioning energy flux density max. The other thing that you can obviously change is the frequencies when it comes to your methods and methodologies. So typically, both machines that Swiss DolorClast are currently offering offer between 4 and 20 hertz. The Master Touch will deliver 1 to 20 hertz all the way through it. Your Smart 20 unit will only provide you with 4, 8, 12, and 20 hertz. Most of your frequencies that you use during a conventional session and a treatment will be between 8 and 12. So they can deliver the perfect settings. It's just that you can be more personalized with a Master Touch unit. And I'll show you the interfaces in the next slide. Shocks. So this is, I should change this really to impulses, because it's technically not shocks, because as I said, shocks implies electrical impulses, and there's none of that. Now, that's all it is though, is the number of impulses that are provided per session. And that typically ranges depending on the condition that you're going to be treating and what the evidence in the literature says. Most cases and most protocols will be between 1,500 and 2,500 impulses or shocks per treatment, but that can be more and less, or less. I think if there's people out there certainly who are big into shockwave at the moment, they are stating that they can get better outcomes from using trigger point treatments as well, in combination with the primary site of pathology. So that's where, you know, on our advanced course we talk about that a little bit more, but maybe just because we're saying 1,500 to 2,500 per treatment protocol is what you would expect, it doesn't mean you can't go above that if you are using for trigger points, etc. So on the next slide, we're going to talk about the machine interfaces really, and the face of them. And this is the Master Touch unit. And what we're looking at here, as you can see, the 4 settings that are represented on the screen. We have pressure, we have impulses or shocks, and then the frequencies at which they're being delivered at. Now, the app, as you can see as well, is that there's a little section down below that for the applicator head size. And there's a reason this is here. Remember I was saying that you can convert energy to bar and bar to energy. Well, if you look at the bottom right-hand side of the screen, there's a little plus, a circle with a plus on there, and that says energy. Now, if you press that button, that will immediately convert your bar to energies, which is saves you. So, for example, it's easier then to mimic or replicate the methodology for a certain condition that you've seen in the literature. But that you can also get conversion charts as well. So that isn't essential, particularly if you look at the Smart 20 unit here. It's not as an interactive interface. However, you can deliver the same outcomes. So you can get the same performance with this unit. It doesn't deliver up to your 10,000 impulses in one go. You have to go to 2,500 and then start again. But the only reason you would need 10,000 impulses was if you were treating cellulite reduction, really. Frequencies, obviously, as I said, they're not as tailored, so they can be 4 hertz, 8 hertz, 12 hertz, and 20 hertz, whereas the Master Touch will deliver anything from 1 up to 20. But as I said, most frequently we use between 8 and 12 anyway. So again, good performance, ample settings. This one is like the old dial tones that we used to have in England and Wales and the UK. So you just touch around to get your pressure settings. Okay. So we're going to talk about the applicator size, and this is really significant when it comes to the amount of energy that we want to be delivering into a tissue. So I've got these two applicator heads here. This is a 15mm applicator head. There. And this is your 36mm head. Okay. Now, if you compare those, this 36mm head actually has 4 times the surface area. So what's the significance of that? And we can demonstrate that with conversion charts and when we look at the energies. So if you remember the definition of energy flux density max, that would be the maximum amount of energy that can be delivered per defined surface area. So if this has got a 4 times greater surface area, in theory, we're going to have a significantly less amount of energy that's being delivered with this applicator head because it's a larger surface area, even though we're having the same energies delivered into the applicator or into the handpiece. Because this is a larger surface area, we're going to get significantly less energy delivered into the tissue. Whereas we're going to have significantly more energy delivered with a 15mm head. And there is a theory and there's reason and method to the madness as to why that's important. Now, when we look at the energies, for example, with a 15mm head, which is this one, at 2 bar, you were delivering 0.06 millijoules per millimeter squared. At 2.5 bar, 0.11. At 3 bar, 0.13. At 3.5 bar, 0.16. At 4 bar, maximum energy output with these units, 0.18. And that's if you're looking at the Evo Blue handpiece. If you have a power handpiece and the power red handpiece, which I'll talk about very briefly later on, that can actually deliver up into 0.4. Now, when you consider that those handpieces are more often used on horses, it actually, you know, you don't need that amount of energy to have a therapeutic effect on humans. But you compare that to 36mm head. At 2 bar, we're delivering 0.02 millijoules per millimeter squared. 2.5 bar, very similar, 0.02. 3 bar, 0.02. It's not until we get to 3.5 bar that we actually start to deliver 0.03, and at 4 bar, 0.03. So we are delivering significantly less energies because we have a larger surface area with this. And there is relevance for this because to have a therapeutic effect on a tendon, we want to be delivering anywhere between 0.1 and 0.2 bar. 0.1 and 0.2 millijoules per millimeter squared. Now, if we go back to that conversion chart, realistically, the starts are around about 2.5 bar. and then all the way up into 4 bar. With a 36 mil head, we're not really going to be achieving those therapeutic outcomes. However, that doesn't mean this isn't useful. So this can be really useful for those hypersensitive patients, the patients that really cannot tolerate high pressures or high workloads. So you could potentially increase the frequencies and then use higher energies. So 0.03 going up into your kind of, the 4 bars on the machine, but that would be different because of the applicator head. So you could be using higher frequencies with a larger surface area or the 36 mil applicator for those patients that maybe can't tolerate it. So that's the relevance for this, is that realistically, to have a good therapeutic effect on the tendon, we do kind of need to be cruel to be kind and get quite high energies into them with the 15 millimeter head, because that's the ranges that we have good therapeutic effect in. Okay. So we're going to talk about how it works now, and I think that that's kind of the most important element of it. We see anecdotally great results, but we want to know why. Well, I certainly did. I was very inquisitive, so I wanted to know why this worked. And what we know is that the current evidence base is suggesting that there's an interplay between mechanical effects, biochemical effects, and pain relief mechanisms. And this pain relief mechanisms I'll talk about, but that's exactly what we were talking about, what we would achieve by using higher frequencies with a larger head, is that we create this hyperstimulation, which then results in pain relief. And I'll talk about that in a little bit more detail. So we're going to talk about the mechanical effects first. And this is just a physical representation again of a shockwave. So we have in the light blue, we have this positive peak area. In the dark blue, we have this negative energy density. And that combined, the light blue and the dark blue, is the total energy density that will be applied during one shock. Now, the positive energy density is the compression phase. So this is the first phase of the shockwave. And this is purely responsible for causing shear and stress on the tissues. So the cell membranes, we basically stimulate the external cell membranes, which then creates a cascade of events. So this is something that we call mechanotransduction. Again, we do talk about that a little bit more on our advanced courses, but mechanotransduction is essentially responsible for the cascade of events that leads to chemical reactions and tendon homeostasis. So that compression phase is essential for that. Then we have the tensile phase. And this tensile phase is what's responsible for the production of cavitation. And again, cavitation is essential to have a mechanical effect, because actually those cavitations, those bubbles, I'll show you what happens in something called shadowography, which is really hundreds of times frames per second. But the cavitation is produced at that negative energy density phase. And it's essential that your machines are producing cavitation, because cavitation is what's responsible for the majority of the mechanical effects. Okay. So this is going to be a demonstration of cavitation in a glass or in a plastic container. So this is the old classic unit. This is one of EMS's first units, I think. So what we're seeing here is 2,500 impulses at 2 bar 15 hertz. You can see the production of cavitation within that water. We go up to 2.5 bar here. And as you can see, there's possibly, well, there's slightly more cavitation being produced, and it's actually penetrating a little bit deeper within that glass as well. It's probably about 3.2 bar actually, but 3 bar just for purposes. And again, more cavitation, more bubbles, more penetration, and deeper into that glass that's going. Now 4 bar is the maximum setting. Really a significant amount of cavitation being produced at this point. And the key thing as well is that it's consistently producing cavitations across the treatment. So some other machines and some other units which have been proven through the literature, which I'll talk about in 2 slides time, is actually we know that the energy drops off midway through that treatment. With EMS machines and Swiss DolorClast handpieces, actually they redesigned it as a result of evidence saying that they basically wasn't performing as well as what they hoped. So they redesigned it, recreated the handpiece. And this is what I loved about EMS was that, and Swiss DolorClast, was that they found a problem with the equipment and then they actually addressed it, changed it, and the performance now is consistent across the treatments. So this is now the same with the Power Red handpiece and the Evo Blue handpiece. They are consistently delivering equal amounts of energies and cavitation from the first impulse and from the first shockwave all the way through to the last, which is vital. So we're going to slow that down now, and we're going to really show you what one shockwave looks like in shadowography. So we're going to show you again. Do this a couple of times just so that you can get used to that. So we see this compression phase initially, tensile phase now, cavitation being produced. Okay. One more. Here's the tensile phase. Sorry, compression phase, tensile phase, cavitation being produced. It's compression, tensile, cavitation. Okay. Now, these 2 arrows are representing that first compression phase, which is responsible for the first impulse is going to be your shearing stress and the compression of the tissues. This tensile phase here, see how the cavitation is being produced? Well, those cavitations burst and they create secondary shock waves, which then also cause a knock-on mechanical effect onto the surrounding tissues and surrounding cell membranes. So that's the importance of the cavitation there. So those second shock waves are represented by the circles that you can see on that image to the right-hand side. So this is what I was talking about, is that the importance of cavitation and the production of cavitation. This Power Red handpiece is the one that we're seeing on the far left of the screen. And then we have the Evo Blue handpiece, which is just to the right of that. All EMS and Swiss DolorClast products, they are producing significant amount of cavitation. Now, the competitor handpiece, and this is at 4 bar, competitor handpieces at 5 bar were demonstrated less cavitation being produced. So worth considering. So that's essentially where we're thinking is now, is that obviously, as you can see, there's more cavitation being produced with the Power, is a little bit darker, more consistent, but same with Evo Blue, producing absolutely ample cavitation to have a therapeutic effect. Now, this is one that I really quite like. Has anyone had a really hot chili and you bite into it and then all of a sudden it actually is quite painful because of the actual extent of heat that comes from it? And then after a period of time, you actually go, oh God, that's really numb now. I actually can't taste anything. And that's the process that we liken this immediate pain relief and long-term pain relief to. So shockwave, we know, induces angiogenesis, which is increasing the blood flow to that area. We know that it has pro-inflammatory effects, so increasing the inflammatory reactions to a chronic tendon. But then these immediate pain relief and long-term pain relief is both a localized chemical response and a neurological response as well. And that's what we liken the red hot chili peppers and the heat, the pain and the numb. And that's how we kind of liken that process, is that sometimes when you start shockwave, actually it can be a little bit uncomfortable. and then it can develop and build, and all of a sudden patients become more tolerant to it. And the more tolerant that they get, actually they go, yeah, you can increase that now, you can increase the pressures, you can increase the energies. So that's that hyperstimulation reaction, and I'll talk more about that. Okay, so angiogenesis. What we know from the literature is that vascular endothelial growth factor has increased at the bone, so it's the insertion, really, the bone tendon junction in rabbits. Now, obviously, if we look at that from a really critical perspective, we're thinking, okay, well, that's an animal study, that's fine, but how do we know that that's the case in humans? And then more research was done, and then we kind of said, okay, well, there's definitely an increase in angiogenic growth factors, so eNOS and vascular endothelial growth factors, which are responsible for increasing and inducing neovascularization. And then we also found that there was increased activation of proliferating cell nuclear antigen, as well as increased stem cell activation as well. So angiogenesis, we know that we increase the blood flow to that area and that angiogenic response. From a pro-inflammatory effect, what we know is that we increase interleukin 6 and 8. There's a 5-fold increase of metalloproteinase 2 and 5. And ultimately, there's these chemicals are responsible for tendon homeostasis. We increase fibroblast activity as well as destruction of the pathological tissue. So the key point from the fact that we have an inflammatory response or an inflammatory effect on that tendon is essentially, we don't want your patients to be using naproxen or ibuprofen throughout the course, or even prior to the course of treatment that you are looking to administer. Because if you're inducing inflammatory responses, technically that anti-inflammatory and those NSAIDs that you're going to be taking alongside your treatment is going to be counteracting that inflammatory reaction that we want. And we want an inflammatory reaction because technically, when you look at the pathology of chronic tendons, we're unsure, the literature is out there, we are unsure as to whether or not it's a degenerative, we're unsure as if it's inflammatory. The likelihood is it's a bit of both. So what we want is those chronic tendons to actually kickstart this healing cascade again. And that's the importance of that pro-inflammatory effect. And pain management. Now, this is the hyperstimulation area that we were talking about. What we know is that if we stimulate and we get prolonged activation of those C nerve fibers, it leads to a reduction of substance P and reduced calcitonin gene-related peptides. So we get prolonged reduction in the release of substance P at the site of, well, technically at the site of pathology, but also at the at the spinal cord. So in between the first order neuron and the second order neuron. There'll be a diagram just to explain that in the next slide. But we also know that we get this, because we stimulate the periphery so much, we get this temporary destruction of unmyelinated nerve fibers. And it's actually these nerve fibers that are responsible for this like throbbing pain that we experience at the periphery. So shockwave not only has an effect on the peripheral, but also has an effect on the central nervous system. And this is actually for podiatrists and physios that inject. We actually know that shockwave doesn't work as well under anesthetic. So possibly because we're having this neural effect, if you are numbing that, you're limiting that neural effect and therefore having less of a significant therapeutic response going through. So quite interesting. And here's that diagram that we were talking of. So the pain neurotransmitter represented as 4 circle dots in between the first order neuron and the second order neuron. This is the site of the neurogenic inflammatory response. Now, if we reduce the substance P in between those two nerves, or in between the first order neuron and the second order neuron, we are therefore limiting the painful signals that are being sent to the brain. So as we know, pain is in the brain. So if we can limit that, perfect. So You know how it works. I think the key thing now is knowing when to use it, when not to use it, and when is it appropriate, and is there any contraindications to care. So we'll look at some indications and just rough guidelines here. So the key thing is that if you have maybe a condition that is recognized to be responsive to shockwave therapy, you can absolutely treat that. NICE do state that they prefer a diagnosis via MRI or ultrasound. However, not essential. Your clinical diagnosis is often enough with that. So don't panic if you're thinking, oh God, I've got to send everyone out to MRI, or I've got to send everyone for ultrasound scans. That's not necessarily the case. Your clinical judgment is absolutely efficient and sufficient to say, okay, well, we can crack on. Certainly in cases where you're thinking, well, which I'll talk about if they fail conservative management, or if there's maybe more invasive procedures that are required, shockwave is certainly less invasive and safe and effective. So, well, certainly safe and effective to carry out. So it's absolutely fine to treat the majority of patients with it. Typically, we know that if you've got this case, or if you've got this condition for longer than 3 months, or maybe longer than 6 months in certain cases, I know that the literature is out there to say that Achilles will respond better if it's been present for longer than 6 months. So it's a really, one of those chronic conditions really responds better to shockwave therapy. If the patient has failed conservative management, and certainly this is something that we see in clinic a lot, the patient that comes to mind here is a patient of ours that he actually presented with bilateral golfers and tennis elbows, so his elbows were in bits. And he was referred to us by a sports physician, a local sports physician, and he was saying, you need tendon debridement. This is the next stage for you. However, go and try shockwave. Let's send you down to Dan. Let's see if he can have a look at it. So I had a look at it. We spoke to him about it, explained obviously the process. And he said, okay, yeah, do you know what? I'm going to do one elbow first, because if it works, I'll then do the other one. If it doesn't, I don't necessarily want to go through the pain and the discomfort that is associated. So he said, okay, we'll get that done. So we did it. After 3 sessions, he had a 70% reduction in his right elbow. So then on the review stage, he wanted to commence with his left. We did the same process. And at both review stages, he was 80% pain reduced with increase in his grip strength due to the rehab stuff that we've been doing. So really good for those. Sometimes, obviously sometimes they don't respond, but that was one of those little ones that I'll always take and go, that was amazing that we were able to get that result from that patient who was due to undergo surgical intervention. And as you go, next point is if surgery or other invasive procedures are the only remaining option. So they kind of come in a part of the same, those 2 points, because often if you fail conservative management, the next stage would be a surgical intervention. So it does fit in between those. And even there is argument to say that realistically, shockwave therapy should be your primary protocol beyond or prior to any form of injection, due to the risks of rupture, etc., with the injection. So that was a ROMP study actually done in 2009. So that literature's there as well. We can only do this though if there are no known contraindications to care, and I think that's the key one really, is that if there's no known contraindications, you can really try it, but obviously let the patient be aware. We tend not to go outside of the box too much, but let them be aware, if there's maybe a little bit of an experimental, which there are experimental kind of pathways and protocols out there. But for this purposes, stick to the next slide, which will show you your generalized and accepted indications. Okay. Oh, sorry. The next slide after that will be the indications, I think. So what we've got is, basically, we shouldn't perform it over air-filled regions. So, or if there's been a pre-rupture tendon, if there's been some pregnancy, if your patient is currently pregnant, if the patients are under 18, and we say except for Osgood-Schlatter's disease, and there's a reason for that, Osgood-Schlatter's disease has been shown to be safe and effective. Now, the study that was done for that was actually, it was a relatively poor study in actual sense. It was showing that there was there was no control group, so we couldn't tell if there was a better outcome in shockwave compared to standard conservative management. But the key thing was that actually there is no significant side effects, and there was no side effects or reported side effects for that population group. So we were able to say in the back of that literature that, okay, this is a safe procedure to carry out for those patients. Now, a lot of people ask, is there any, what's the difference between Osgood-Schlatter's and Sever's disease beyond location, obviously? And the truth is that from a perspective of safety, because that literature hasn't been carried out, it's not an accepted protocol. So ethics is obviously going to be the issue, because you're dealing with people who are under 18 with open growth plates. And if you state that the risk there is that potentially you can stimulate the closure of that growth plate, ethics are going to be a difficulty, okay? So that's why Sever's probably hasn't got that research in abundance yet. Patients with clotting disorders, obviously we would avoid, and patients who are currently being treated with oral anticoagulants. We definitely wonder if there's any tumours or localised infections, and recent corticosteroid injections. Now, I think that's on here. We leave off 6 weeks for the upper limb for corticosteroid injections and 8 weeks for the lower limb. Okay, so just to let that get out of the system, and we can then progress with our shockwave therapy after that time frame. One reason is that there's that perceived increased risk of rupture. And the second one is actually, as I said earlier, corticosteroids going to be reducing that inflammatory response, and therefore reducing the efficiency and the efficacy really of your outcomes and your treatment. Okay, so here's the list of conditions that we would typically treat. We have lateral epicondylitis, medial epicondylitis, subacromial pain syndrome, calcific tendonitis. Now, with subacromial pain, I think that it is worth noting that there is literature out there that would say that there's no significant benefit to the addition of shockwave therapy compared to conservative management for subacromial pain. And I think a lot of that comes down to the diagnostic factors. When it comes to subacromial pain syndrome, what is that? And I think that's the big question, is that what tissues are playing a role? Are we looking at a bursa issue? Are we looking at this being more of a rotator cuff tear? Are we looking at it being a true tendinopathy? And that's where diagnostics can come in quite useful. Calcific tendonitis, on the other hand, abundance of literature out there to support that. And it actually says that, the use of shockwave therapy for calcific tendonitis is better than conservative management alone. And also, we're saying there is literature out there now to actually recognize potentially the patient groups that are less likely to respond with a calcific tendinopathy. So that would be if your calcification is present for longer than 11 months and larger than 15 millimeters, there's less likely to have a complete reabsorption of that calcium. However, that doesn't mean that you can't improve the function and decrease pain with shockwave therapy in that patient sample. It will get that. There we go. Greater trochanteric pain syndrome is an absolutely fantastic one tends to be your inactive population and middle-aged, really, greater trochanteric pain. Again, though, this does come with sort of areas, because it's a pain syndrome. Is it the tendinopathy? Are we looking at a greater trochanteric bursa? Are we looking at maybe a partial interstitial tear of the glute max? And I think that we have to be aware of the glute max with this condition, because the glute max is quite debilitating if there is a partial thickness tear or an interstitial tear within the glute max insertions. So just be aware of that. Patellar tendinopathy, now these are typically difficult to manage in season because they're always going to be athletes that will develop a patellar tendinopathy, as it's jumper's knee. It's always going to be an athlete that will develop patellar tendinopathy. It's very unlikely that you're going to be a sedentary person developing a patellar tendinopathy. So what we tend to find is that most of these athletes are in season. They maybe have spiked their load a little bit, and that's where Shockwave can come in for pain management, as well as their load management and load progressions that would be done with either yourself or the club or whatever. But it does tend to be an active patient population that will result in patellar tendinopathy. Osgood-Schlatter's disease, as I said, is recognised as a safe condition. Medial tibial stress syndrome, if you do have the pleasure and the luck to come on to a course with us in the UK, Chris is normally Chris is the UK sales rep, as I mentioned earlier. Chris is normally the lucky participant who will sort of volunteer for this one. It's a little bit uncomfortable, I will say that, but it is really effective. We also use this for Achilles tendinopathy in mid-portion and insertional Achilles tendinopathy, with abundance of literature to support both. Now, the key thing as to why we've separated them is that actually we talk about this in our advanced courses, but they are completely different in their histological appearance, the insertional and the mid-portion of the Achilles. They appear completely different in a histology perspective. And the insertion really, they do respond slightly differently. So the insertion maybe, in my opinion, in my anecdotal opinion, takes that little bit longer. And it may be because there's this completely different type of collagen that is at the insertion of the Achilles than mid-portion. So we start to get a more cartilaginous appearance at the insertion than we do of a collagenous appearance in the mid-portion. And then obviously plantar fasciopathy, which is so much literature is out there for plantar fasciopathy, and I'll show you that on the Pedro database in the next slide. So, as I said, what's the evidence saying for all of these conditions? And this is a Pedro database. I think that there's a new Pedro database out now with 60 RCTs, but this is looking at 45 RCTs. 30 of the 45 randomized controlled trials stated on this Pedro database are all using Swiss DolorClast machines. So 80% of the studies using Swiss DolorClast machines had positive outcomes. And if you delve into it, really those 20% that were having less favorable outcomes, probably the methodology could be criticized. They maybe weren't using enough energy to get sufficient outcomes. There is one study which stands out for that, which is a study that was done in 2016 by Kaplan et al. And they weren't using a Swiss DolorClast machine actually, but they were using 1.8 bar for a lateral epicondyle or lateral epicondylopathy. And as we said from earlier, when you look at those energy conversions, you don't really start to get a good therapeutic effect until around about 2.5 bar. So if you look at that and you're saying, well, they're averaging 1.8 bar throughout their treatments, that's nowhere near enough energy to get a good outcome. So you can criticize some of the methodologies based on that. When you look at the literature here, I believe there are 16 studies looking at plantar fasciopathy. So the lower limb stuff is really there. It's in abundance. The Achilles is there. The plantar fascia has been there. And it actually stems from probably one of the earliest interest in musculoskeletal medicine with shockwave therapy was in the plantar fascia, heel spurs, and non-union fractures. So, you know, that's probably why this research has been going on for a long period of time. So, I'm happy to take any questions based on that. I think that we should just do a little bit of a conclusion. I think that when if you have any questions regarding any of the training courses, they are run annually. Obviously, at the moment, we're doing what we can with trying to do some online webinars with you and trying to get as much sort of you guys involved as possible. If you do want more information, you can contact Chris on his email there, which is chrisdownton@ems-ch.com. And his mobile number is also there if you have any sales inquiries. If you are a DolorClast user, you can join us on our Facebook group. but also you can follow Swiss DolorClast International on Facebook and have a look at YouTube as well. I think that there's some really good videos actually coming out there. I was a little bit surprised actually that we posted one of my interviews that we did on the course not so long ago regarding knee osteoarthritis. So there's a lot of good kind of content coming out from EMS at the moment. And you can also find your practice in an online directory online. So happy to take any questions, really, MC.
Yes, thank you, Daniel, for sharing all this expertise in shockwave therapy. Actually, we have a question from Theodoros from Greece, who was asking what are the indications of the use of a 36 millimeter applicator?
Okay, so the 36 millimeter head we tend to use along maybe the musculotendinous junction. So we kind of run, and exactly as I was saying as well, is that if you have that patient that is really hypersensitive and can't tolerate a 15 millimeter head, then we can really use the 36 millimeter head there to create this hyperstimulation, which then creates this immediate pain relief almost. And then you can start to increase the energies from there. So this is a really nice applicator for those patients who really can't tolerate it. So if they come in with a 9 out of 10 pain, you might want to think, well, you know, are they going to really want you to supply all of that energy into that tendon, and can they tolerate it? And if they can't, that's where the 36 mil head comes in quite nicely. I do also use it for muscle work a lot. So if we're going up into higher frequencies, I tend to use it at the musculotendinous junction quite a lot with the Achilles, certainly, and definitely as well with the hamstrings. It's a really nice hyperstimulation one. I quite like it for that, actually.
Okay, thank you, Daniel, for sharing these recommendations. We have a question from Richie, who wants to know if RSWT can do such as peripheral nerve blocks for e.g. cluneal nerve or genicular nerve.
Oh yeah, right. So I did read that. Now we tend not to, we tend not to use it on peripheral nerves really. I think that there has been reported outcomes of peripheral neuropathies from shockwave therapy. So, and actually that, again, when we spoke to someone who, that case was from South Korea and it was in the ulnar nerve. And when we spoke to someone from South Korea regarding that, they actually said that, well, they didn't know whether or not that was from the shockwave or not. So it was quite an interesting one. Normally the effects on peripheral nerves tend to be a side effect. They're not something that we tend to target specifically. However, it is a little bit beyond our normal scope. It's not something that I would typically do in clinic. There may be literature out there to say otherwise, but from my perspective, it's not something that I use, and it's not something that I regularly will carry out.
Okay. Thank you. Thank you for this answer. We have a question from Jima, who's telling us that they've been supplied with recently with the DolorClast machine, and asking if we will be doing any webinars on how to use the machine, and also what is the maximum number of treatments.
Okay, so as it stands, I'll go to the number of treatments first, and then, I mean, I'm open to doing practical sessions. There's no issues with that. It's just whether or not there's a demand and whether or not, you know, EMS and DolorClast want to put that on. So from my perspective, I'm not going to put any pressure on MC here, but I'm happy to do any kind of practical sessions. But from the perspective of sessions and protocols, what we tend to do is we tend to use one session per week. Okay. Now, from NHS protocols, which is obviously our health boards, and that can vary between health boards, but what we tend to use in our area, and certainly what I use in clinic in private practice is that we'll do one session per week for 3 weeks or 4 weeks, depending on the condition. I tend to do 4 weeks for proximal hamstring because there's literature to say that actually 4 sessions is better than 3. So we do once a week for 3 or 4 weeks, and then we maybe do 4 to 6 weeks, and then we review them. At that point, we may expect, or we should expect, if their load-in has been appropriate and they haven't really flared it too much, that they would be around about 60 to 70% improved. That would be ideal. Now, on occasions, you then have a discussion with them. You can then, ultimately, it's their finances, certainly in private practice. You then have a discussion with them and say, do you think you could manage this with your load, or do you think that you need a further 3 sessions? And in which case, you can crack on with the other 3 sessions. Now, the NICE guidelines are stating that anywhere between 3 and 6 sessions is adequate and appropriate. From the perspective of literature, there is no maximum amount of sessions that you can carry out. However, you might want to start to really query and question your justification for continued care if there's no response at around about that 6th session. For me, if it's not working, or if there's no improvement after 3, I tend to think, okay, well, we need to look at something else now. And that's like if there's 0%. If you're on 10%, 20%, there's definitely evidence to say that you will benefit from a further 3 sessions. However, if you are looking and you are struggling after the 3 sessions, and they're like, do you know what, this is exactly the same, you maybe need to query your diagnosis firstly, and maybe look for some alternative imaging to confirm what you were thinking, or maybe that's something that may highlight that what you weren't thinking.
Okay, thank you, Daniel, for this detailed answer. And thank you, Gemma, for joining us in the DolorClast Shockwave community. We have a next question from Gerard Stengel. Do you use shockwave therapy for new acute injuries?
Right, so there is more literature coming out now at the moment for acute cases. This certainly is for muscle injury. The majority of it is in chronic at the moment. There is literature out there for acute. So, you know, it is there. It's not as strong. You can use it to increase the blood flow, certainly to the area with muscle injuries and things like that, which acute muscle strains. Not really, really acute, you know, not a day or 2 old, but certainly even in Bundesliga, they use it at half-time to stimulate the muscles and keep them rejuvenated. So realistically, it's not out of the question. There is more and more literature coming out on that, but it's not where the majority of its usage is.
Okay, thank you. Same user, Gerard, has another question. How would you use shockwave therapy on the spine, and what for?
Okay, so yeah, this is quite a nice one. We demonstrated this at one of our courses not so long ago, actually, and we had a delegate on the course who was quite she was quite struggling in terms of her flexibility and her movement, and I think it's probably from sitting down quite a lot all day, and she was getting a little bit of a bad back. And we used it around the erectors. So we used it 3 separate points on bilateral erector spinae. And that was with 15mm head. So angling medially so that you basically shockwaves we know can't penetrate bone at these energies anyway. So when you're angling medially, you're safe. You know, you're not going to be into any air pockets or anything like that. Because the major concern is that you're going to be applying this into the bowel if you've got 4 centimeters of penetration, and you could potentially be, you know, into the air cavities within the bowel. So if we angle medially towards the spine, we're safe. You're absolutely safe there. We also know that, you know, in the majority of people, the erector spinae are around about 3 centimeters deep. So anywhere around about 3 bar is going to be perfect for that. And we can just literally, you can do some trigger point work and angle in. You can maybe use the 36mm head and run up and down as well, which is great. Now, we tend to use it, and I've certainly used it more recently in kind of mechanical, non-specific mechanical low back pain. I haven't used it for discogenic type of pain, and that's maybe just because I'm a chiropractor, so I kind of feel as though, you know, we've got our toolkit for that, and the rehab as well, but also it's maybe the additional risk of the unknown. Is it going to flare anything up maybe? Not that there's any evidence to say that it will, it's just that theoretical. But yeah, from a non-specific mechanical low back pain, it works really well. Certainly if there's maybe a little bit of spasm within that musculature as well, works fantastic for that.
Great. Thank you, Daniel, for sharing your expertise on this indication. We have a question from Eric. Is there indication for trigger finger and carpal tunnel syndrome?
Right, okay, yeah, so there is some literature for carpal tunnel syndrome, and there is some literature there for trigger finger. I've certainly done it in clinic. It comes under an experimental bracket, so it's not an accepted use. Now, EMS have approved uses and approved conditions, whereas I think it's the, let me get this right, it's the ISMST, I think it is, that have a sort of another list of multiple lists actually of conditions that would be deemed as experimental, exceptional, approved, and just, you know, not really safe. So there are other lists out there beyond the approved ones of EMS. However, obviously we have to stay within those boundaries and those guidelines at the moment. I've used it in clinic for trigger finger, and I've actually had really good responses for trigger finger, because it's, well, you know, Dupuytren's is difficult. My colleague Johnny Ride has had some fantastic results with Dupuytren's contracture, and prevented, I think, surgery. She was it was quite an advanced case. She was able to get full range of motion in, I think, around about 3 out of the 5. And I think only the 1 was struggling to respond at the Dupuytren's contracture side. But you could trial it. And I think that when it comes under the indication perspective, if you think, okay, well, conservative management has failed, surgery is the next invasive procedure along the line, if there's no risks with it, why not? If there's no contraindications to care for that patient, you can certainly try it.
Okay, thank you very much, Daniel. We have a question from Fazlullah from Pakistan. Does the size of the applicator varies from injury to injury?
Okay, not really. It is dependent purely really on tolerance. So, for example, again, if you've got an Achilles or if you've got a plantar fascia that is unable to tolerate, it's more about its application rather than the condition. So it's the logic behind what you want to achieve. If you want to produce some hyperstimulation and the patient isn't able to tolerate the 15 millimeter head, then the 36 millimeter head is absolutely the right decision and the right way to go with that. Whereas it doesn't matter if that is a hamstring, if that is a shoulder, if it's a tennis elbow, it doesn't matter on the condition. It's more about the practical use and what your desired outcome from using that applicator is, if that makes sense.
Okay, thank you. On my side, actually, I have a question.
Okay.
I don't see any other question. We are all working from home, and I was wondering if we could use shockwave therapy to treat cervical pain, because we tend to stay to sit down and stay in the same position when we are seated. So can we use it for cervical pain?
I tend not to. Again, but this is predominantly because I am a chiropractor. It doesn't mean you can't. I think you have to be certainly aware of the lung field within the, up in the upper thoracics, because, as you said, going all the way back to kind of World War II, if you're using in the thoracic region, there was increase. So shockwaves were originally discovered because there was explosions going off and we were causing pneumothorax and intra-abdominal injuries. And so we found that the effects of shockwave can have low-level side effects, certainly onto the lung and into the abdomen. And that's one of the things and one of the risks that we have with using it up into the upper cervical spine and into the thoracic regions. It doesn't mean that it can't be done with its correct application. It's just, it's more of a risk there. I mean, you've got a lot of sensitive structures up there, etc. You've got arteries. So, I mean, realistically, you can go over into the traps. There's no reason why you can't do that with the 36 mil head. The one thing that you've got to bear in mind is the depth of penetration and the pressure. So as a rule of thumb, we use 1 bar as 1 centimeter, 2 bar as 2 centimeter, 3 bar, 3 centimeter, etc. for the level of penetration that you can achieve for the 15 millimeter. So if you were suspecting that there's any really kind of vulnerable structures within that depth, you maybe wouldn't want to use it. But again, you can certainly use it up into the 36 millimeter head, over into the traps, running down into the thoracic erectors, for example. It'll work quite nice for that.
Okay.
So it's about the correct application there, MC, rather than the actual, obviously over the brain is completely contraindicated, but onto the skull is a little bit sketchy, but otherwise fine.
Okay, thank you, Daniel. We have another question from Richie concerning osteoarthritis. Is it effective for the pain and for the arthritis itself? Right,
so really interesting this. When it comes to osteoarthritis, we know that it's really effective for the knee. Beyond that, there's a little bit more literature that needs to be done and more research that needs to be done, particularly with shoulders, for example. We know that it's really effective for pain management in the knee, and specifically we use the applicator and we angle it at the medial tibial condyle. What we find is that I've certainly had a case recently, it was actually just before lockdown, where we had a patient in who was struggling to really walk in work. He was a butcher, standing on his feet all day, and his knee was becoming quite problematic. We did 3 sessions, 1 session a week for 3 weeks. 3 weeks later, we did a review, and it was that review session that was the week before we locked down. Spoke to him, and he said, I did 10,000 steps yesterday with no pain. So it's really effective in the sense of pain management. Unfortunately, what we know about shockwave, what we know about osteoarthritis is that it's irreversible. We're not going to change the actual, arthritic degeneration that is prevalent within that cartilage and within that joint. But the literature that is out there is actually saying that we can prevent further degeneration of that cartilage through shockwave therapy. And the process and the thought process behind that is that actually we're increasing the blood flow up. And they were rat studies, unfortunately, so this hasn't been proved on human studies. But from the perspective of the intervention that was carried out with the rats, we know that there is literature and evidence out there to say that, okay, we can maybe prevent the further degeneration of that cartilage, but we can certainly have an effect on pain. And that's the key thing, is that we can reduce down pain with these patients. And again, with these type of patients, if there is a severely degenerative knee, I tend to use the 15 millimeter head with these, but you can use the 36 mil head. It's not as effective, but it does create this hyperstimulation. So if they can't tolerate it into that medial tibial compartment, which is quite tender and it's very bony, as we apply it into there, use the 36 millimeter head if they can't tolerate it. Or alternatively, increase the frequencies because that makes it more tolerable in itself.
Thank you very much, Daniel. We don't have any other questions in the chat. On my side, I have another question. I wanted to ask you if you have ever used the DolorClast on bone unions, non-unions.
I haven't.
I haven't.
The reason is that I'm obviously in a private practice, so we tend not to see them because chiropractor, etc. So I don't tend to see them. However, again, colleagues of ours have used them. It is quite painful, and they do need a little bit of energy into them to be able to stimulate that bone growth. But seems to be really effective. And again, this is where one of the earliest literature was carried out, was in non-union fractures. So there's an abundance of literature there available for that. I don't do it, unfortunately, because I don't, they're very few and far between you come across it. I'd be happy to. It's not saying that I wouldn't. It just means that I've never had one in clinic. But again, that doesn't mean that it can't be done.
Okay, thank you.
That's okay.
I have another question.
Go on, yeah.
Would you use it for frozen shoulder?
Yes, definitely.
And could you combine it with I don't know, with ice, for example, or cryotherapy?
So yeah, I use Shockwave on frozen shoulder, and it has been a game changer for me. Frozen shoulder is obviously a condition that is so long lasting, maybe 24 months natural history. So we're looking at a 2-year natural history process. Now, we on the course, we normally show some kind of like personal experiences, and we share those on the slides. Now, again, frozen shoulder is one of those ones that I actually normally show on those slides, because we had a patient who was really unable to reach her belt line on her trousers with her external rotation. She couldn't get there. Now, after 3 sessions, 1 session a week, we had her achieving mid-back. And this is a condition that will take 24 months to resolve naturally. Interestingly, on a course that we did in Glasgow last year, there was a practitioner there, a delegate there actually, who was carrying out research on the use of shockwave therapy in combination with corticosteroid injection. Now, we've said that that is a complete contraindication here, but that may change providing the ethics were approved. Now, if the ethics were approved for that, because the thought process is the corticosteroid will immediately reduce down that inflammatory response that is going on within that capsule. Now, the shockwave then applies the mechanical stimulus to be able to promote movement and creates this mechanotransduction and again that cascade of chemical events. Now, if we can combine shockwave, it may mean that shockwave with corticosteroids may mean that we can actually increase outcomes sooner. Because what we tend to do at the moment is we have to wait for that acute inflammatory phase to die down and then shockwave it. But if that research did go ahead, it would be really interesting to see outcomes of it. And it would be really interesting to see if there's any increase in side effects from it. So it's one to keep an eye out for if it did go ahead and if there was any ethical approval for it. I'll actually contact them and find out, but that it's definitely, without the corticosteroid stuff, 100% really, really efficient. And again, you can use it, corticosteroid, immediately to reduce down the inflammatory response and then wait 6 weeks and then start shockwave. You can even do it with hydrodistension or hydrodilatation as well. So, you know, you've got avenues and options with that. It hasn't got to be used purely in isolation. So yeah, but it's one of my favorite ones actually to use.
Okay, thank you for sharing your recommendations. We have a question from Elliot. Hi, Elliot. For anecdotal efficacy, how would you include in the consent process, especially when the advertising standards suggest your profession cannot treat?
Right, read that again, MC, sorry.
For anecdotal efficacy, how would you include in the consent process, especially when the advertising standards suggest your profession cannot treat?
Oh, I'm assuming that may be related to podiatry treating upper limb, possibly, or above hip. Realistically, I think that comes down to the profession. I understand that the advertising standards agency play a big role at the moment. There was a big thing a few years ago with websites, for example. A lot of them were contacted and reported on the results of false advertising. So I think what we do is we have a generic consent form that we will have patients sign as they come in. It's really difficult when it comes from higher than you and your clinic, if that makes sense. Normally your clinic will advise you on, procedures and safety procedures, etc. When that is coming maybe from governing bodies or it's saying that you cannot treat this for whatever reason, and certainly advertising standards agency, you cannot treat this for whatever reason. It's a little bit difficult then. Certainly, I think that we just have a generic consent form anyway, regardless of the condition that we're treating. The risks are technically the same. We just state that there's, the risks are the same throughout any condition. And then we chat them through it and then we have them sign it. I'm not sure if that's the answer that you're looking for, but it is a tricky one because, again, you've got to really look and say, well, should I be treating this area? Am I able to treat this area? If advertising standards agencies are saying no.
Thank you. We have a last question from Theodoros from Greece. In acute injuries, is it good to create cavitation with shockwave?
It's unavoidable. Unfortunately, I mean, realistically, the shockwave is the cavitation, and the shockwave is the physical, the mechanical effect that we're having on that tissue. So it's, if your shockwave isn't producing cavitation, you're not really having as much of a therapeutic effect. That immediate shockwave will obviously produce the compression phases, but then that tensile phase is responsible for the cavitation, and those cavitations produce secondary shockwaves, which then increases that mechanical effect. So it's unavoidable to produce shockwave, to produce cavitation with shockwave with the DolorClast machines. And it's actually responsible for a lot of that chain responses. So yeah, there's no reason why you shouldn't. I think, you're looking at, the muscle injury stuff there and maybe the acute phase. But yeah, I got no problem with the cavitation being present in the acute phase.
Okay, thank you, Daniel, for this answer to this last question. I think we are coming to the end of our webinar. Daniel, thank you for sharing your shockwave expertise. It was great to have you today. Thank you all for participating in this webinar. Well, as a conclusion, we were happy to have you, and we were looking forward to having you, joining you online for our next webinars. Our next webinar is planned next Wednesday and will be dedicated to the lower limb areas, correct, Daniel? Yeah. Correct me if I'm wrong. And so if you are interested, registration will be available as of tomorrow, so on Facebook and on the SDCA website. So please join us if you can make it. And we will, of course, We invite you to consult regularly our SDCA website for the courses we will organize in the future when we will have more visibility on the situation. And also, please consult the dates for our coming webinars. Daniel, thank you again. We were happy to share with you all these questions. And for participants, if you have any other questions, please send us an email and we'd be happy to answer them. And we will share with you the Q&A session with you.
Perfect.
So thank you all. Take care, and we see you online next Wednesday for the next webinar. Thank you so much.
No worries. See you next week.
See you. Bye-bye. Bye-bye.
Bye.